A recent article was entitled "Welcome to the Age of the Patient," and although it was mostly focused on describing how a customer relationship management or CRM tool can help manage analytics, deliver patient engagement strategies, and contribute to a positive patient experience of care, the fact remains that patient engagement truly is about bringing the patient into becoming an active participant in the healthcare experience and in adopting a healthy lifestyle. Patient engagement has also been referred to as patient self-management or patient activation and was first formalized as an activity in New Zealand. Perhaps its earliest advocate in the U.S., back as far as 1998, was Hibbard. Using the term patient activation, she raised consciousness of the importance of getting individuals to become more knowledgeable about their health conditions so they have the skills to make health-related decisions and the confidence to activate their skills to achieve better health outcomes. CMS has been a strong proponent of patient engagement, recognizing that especially for those with chronic conditions, patient engagement helps them achieve a higher quality of life and have lower costs for managing acute exacerbations and complications. In their latest strategy launched in late 2016, CMS also incorporates family and other caretakers as an important support mechanism. But they also recognize that providers are accustomed to giving directives, and patients are equally accustomed to getting directives, even as they may make choices, sometimes unconsciously, about the directives, such as deciding they can't afford to pay for a medication or to splurge on an extra helping of fried chicken. As a result, they have outlined provider responsibilities and provide a playbook for them to learn more about the benefits of patient engagement. We'll talk more about this when we address shared decision making. The Internal Revenue Service Initiative is even doing its part in promoting more community engagement. To maintain their nonprofit status, such hospitals are required to submit to the IRS annually a Community Health Needs Assessment, which is intended to demonstrate the needs within the community that a hospital then prepares some of its programs around, such as a clinic van to support the homeless. But we should also look at differences between patient engagement and other similar though somewhat different tools. For example, patient engagement is not compliance, which generally includes some form of penalty. Patient engagement should include learning about how you can become more active in your health and well-being, especially for those who have virtually given into their chronic disease condition. It includes providing guidance in setting an action plan, encouraging patients to use a health diary to monitor how well they are doing on their action plan, and to measure their improvement themselves, especially on medication adherence, sharing their action plan with their specialists, and aiding themselves in becoming more savvy in their own health knowledge. Patient engagement, in contrast to compliance, should be non-threatening. Patient engagement is also not patient experience, although improved patient satisfaction is often an outcome of patient engagement. Patient experience is a process focused on the health industry of learning about how satisfied patients are with their experience of care and increasingly their outcomes. Finally, patient engagement is not solely focused on use of health information technology tools, although again may be aided by such tools. We'll discuss these tools further in this lecture. Finally, patient empowerment might be considered the flip side of patient engagement. Although providers can encourage patients to become empowered through patient engagement tools, patients on their own can, and in many cases are finding it essential to take responsibility for their own care, set their own goals, collaborate with others to learn more, gather evidence from widely available medical literature, and become smart healthcare consumers. Many patients are finding that their healthcare is being compromised by providers and insurers who are giving them short shrift, and so are becoming their own patient advocates, much as we saw in the case studies in Unit 7. It was noted in the last slide that Hibbard was an early proponent of patient engagement. She developed a set of goals for patient activation measurement, or PAM, listed here. The patient activation measurement goals she had were ability to engage in activities that maintain functioning and reduce health declines, ability to be involved in treatment and diagnostic choices, ability to collaborate with providers, ability to select providers and provider organizations based on performance or quality, and the ability to navigate the health system. She also created a comprehensive PAM survey, and subsequently the support from the National Institutes of Health Services Research Program created a short form of the measurement tool. The short form includes only 13 items in comparison to close to 100. The first 4 points provided here as examples of the expectations for an engaged patient. These include, first, when all is said and done, I am the person who is responsible for managing my health conditions. Second, I know what each of my prescribed medications do. Third, I understand the nature and causes of my health conditions. And fourth, I am confident I can figure out solutions when new situations or problems arise with my health condition. The National eHealth Collaborative, now merged with the Health Information and Management Systems Society, or HIMSS, also has made a major contribution in creating a patient engagement framework to guide providers, payers, and other health entities as they help engage patients. This framework includes 5 steps that support a natural progression of engagement for providers. The first is Inform Me. Inform Me is about attracting new patients with various electronic patient education information sources, such as standardized forms, be it paper or electronic, for collection of patient information and advance directives. It is designed to lead to Engage Me. Engage Me is about attracting patients in a practice, such as through specific education and access to their own information, such as via the blue button, made famous by the Department of Veterans Affairs, now also being used for Medicare beneficiary access to their claims, and by some other health plans and a few providers. CMS is also supporting a Blue Button on Fire project, enhancing its current Blue Button service to provide a developer-friendly, standards-based application programming interface that enables the beneficiaries to connect their Medicare claims data to the applications, services, and research programs they trust. The third step in the patient engagement framework, Empower Me, is about retaining patients and encouraging them to take the lead in secure messaging with their provider and to participate in a health information exchange or other similar initiative to enhance care coordination between provider settings. Partner with Me is the phase in which providers integrate patient-generated data, such as preferences, self-care, wellness, and home health device data into their EHRs and connect with public health reporting systems. Finally, the last step in the framework is Support My eCommunity. Support My e-community helps patients and family caregivers connect with community support services, use e-visits, and consider cost comparisons and outcomes reporting in selecting providers. Providers should be in this phase to participate in patient-centered medical home and in value-based care. Now let's talk a bit about shared decision-making and patient engagement. Just as an article title welcomed us to the age of the patient, an article title on shared decision-making, quote, "From doctor is king to patient is key," end quote, further reflects changing communications needed in supporting better quality and cost of care. Shared decision-making, that is also called patient-centered decision-making, is a process where patients are provided with evidence-based information on treatment choices and are encouraged to use the information in an informed dialogue with their providers to help them make healthcare decisions that best align with their values, preferences, and lifestyle. Providing care that is respectful of patients' needs can lead to improved outcomes because the patient was engaged and empowered to make choices. Shared decision-making was part of early efforts to create patient-centered medical homes in the 1970s, though was not recognized as a separate and important process, especially for lifestyle changes such as alcohol and tobacco cessation, drug addiction, diet, exercise, etc., and behavioral health issues such as depression until the 1980s. Patient engagement has not yet fully been embraced by all providers or even all patients. A recent study found that while 70% of patients prefer making medical decisions with their providers, and nearly all could envision asking questions, 93% of whom, and discussing preferences, 94%, only 14% of those patients surveyed stated they would express disagreement with their provider if their preferences were in conflict. Such disagreement was viewed as being socially unacceptable, potentially leading to poor outcomes as a result of being viewed as a difficult patient and then not getting the care they wanted, though as we already noted, this does not preclude the patient from making choices outside of the medical environment, often without the evidence base that the formal process of shared decision-making supports. A bit more on shared decision-making. Much as many other processes and tools we've discussed, shared decision-making can be compared to other somewhat similar yet different processes. Perhaps one of the most obvious is informed consent, which technically is a legal requirement in which providers are required to communicate to patients the risks, benefits, and alternatives relating to a treatment and have the patient sign an acknowledgement that the information was supplied. Many physicians view this as an inconvenience, and many patients sign the form even knowing they do not fully understand what has just been recited to them. But as patients are encouraged to become more vocal advocates of their own health and savvy consumers, the shared decision-making process should support a truly informed consent. Supportive communication is another similar term to shared decision-making. It is a form of communication that is used broadly to elicit the desire for a patient to make good choices with respect to lifestyle changes that are totally dependent upon the patient carrying out the choices. We observe that supportive communication can be an aid in introducing shared decision-making to a patient when the shared decision-making is difficult. But shared decision-making is more specifically focused on reaching agreement about a treatment choice to be carried out by the provider with the patient's participation. Motivational interviewing is another similar term to supportive communication, in that it is focused on helping patients identify and resolve ambivalence about changing their behavior. The technique was made popular by clinical psychologists Miller and Rolnick, who used the technique initially in treating problem drinkers, then expanded it to other forms of substance disorders. More recently, it has evolved and been refined to help those who are ambivalent about their health conditions, especially as found in those with chronic illness. One article has suggested that shared decision-making is most suitable when reasonable options are being considered between provider and patient, where motivational interviewing is more suitable for addressing the need to change a risky behavior. While all physicians would benefit from applying principles of supportive communication and motivational interviewing with their patients, the need for shared decision-making may most likely arise in a clinical versus behavioral health situation. However, challenges such as lack of time, lack of reimbursement for the time, and needing to change communication style have precluded full adoption. In a value-based care environment, however, where best outcomes lower costs, clinicians are well advised to adopt shared decision-making. There are both shared decision-making tools, even with evaluation criteria to assure their success, and a sequence of steps following a systems approach that should make adoption of shared decision-making easier. These steps include 1. Introduce the topic about which a decision needs to be made in a manner that may require supportive communications. 2. Reinforce that a decision about the healthcare alternative right for a patient made in partnership with a patient. 3. Assess pre-existing knowledge and understanding of topic, patient's desire for learning more, what concerns patients may have, their goals and preferred role in decision-making. 4. Identify choices and explain guidelines or standards of care. Use decision aids to help patients. Use open-ended questions to ensure discussion of all pros and cons. 5. Negotiate a decision and resolve any outstanding conflict. 6. Agree on a plan to undertake the topic of the discussion. And 7. Monitor patients' changing needs, wants, and behaviors in addition to clinical progress. Provide supportive communication, additional guidance, and amend the plan as necessary. Now let's talk about patient engagement tools. As earlier noted, patient engagement is not just about using technology, but clearly technology is becoming a significant way engagement is being managed. In fact, the articles for this research almost suggest that technology is the total solution. My personal experience with a provider who refuses to change my gender in my personal health record from male to female, which, since I have no ability to enter any information into my personal health record, means this is incorrect information coming from my electronic health record. I certainly hope that patient engagement is not only about technology, or maybe it should be, in order to signal when it's time to get a different provider maybe. In any event, computing power has opened a huge opportunity for individuals to be more engaged in their health. From the simple to complex, let's look first at the Internet. The Internet enables us to learn much more about health and healthcare than ever before. According to a survey from Google and the Pew Foundation, it was found that 80% of Google users search for health-related information. 66% look for specific disease-related information, and 44% look for information about doctors and hospitals. Patient portals as entry points to request an appointment, schedule an appointment, pay bills, and gain access to a personal health record makes it much easier to interact with providers. The same is true for using social media and email. Providers, in addition to patients, are finding improved office efficiency, more timely bill paying and increased revenue, and generally greater patient satisfaction when such technology is used correctly. I want to point out two studies that were conducted fairly recently. One was conducted by CDW in 2017, the other Nielsen in 2015. Although the 2 years of difference between these two surveys is striking, given the number and types of persons surveyed in each, I would suggest that the actual figures, which we're going to talk about here, are somewhere in the middle, so keep that in mind. With respect to provider responses to patient engagement tools, 67% say improving overall patient care motivates them to improve patient engagement. 83% are encouraging patients to access their health information, with 81% having portals and 53% communicating via email. Patient responses to this survey indicate even more interest in patient engagement. 98% say they can access a portal. 83% say they would be comfortable using a mobile app, 77% texting, and 34% using social media. 29%, however, would give their providers an A for their use of technology. So there's some disconnect there between what providers are saying and what patients are saying actually happens. Both respondents have similar responses, however, to some other questions. 58% of patients to 70% of providers are concerned about ability to have a consultation over video. Both providers and patients at 35% are concerned about familiarity with technology. And 36% of patients and 43% of providers are concerned about privacy. In the Nielsen survey, as I said before, 2 years earlier, they found that 10% of hospitals enable patients to view, download, or transmit health records, which clearly has increased since meaningful use requirements. 15% of patients have email access to physicians, and 20% of consumers have access to online appointment scheduling. And as I said, I think the truth lies somewhere in the middle between those two surveys, one being overly optimistic and one being a little bit old. Personal health records may not have advanced as widely or be as interactive as they could be as another form of patient engagement. There are also issues of interoperability between personal health records offered by each provider with whom a patient has a relationship. And there are issues surrounding acceptance by a provider accessing a commercial personal health record for patient-generated data. In fact, mobile health apps and devices, which we lump together as mHealth, wearables and even implantables, and artificial intelligence assisted care may actually be more acceptable to providers and patients alike over the personal health record. As an example, we talked earlier about apps on fire, and these are becoming ever more sophisticated. For instance, the CMS Patient Engagement Playbook referenced in the last slide includes information about an app called MeTree that enables genomic information to be shared across 3 generations for 48 conditions, including 20 types of cancers, and offers a full report of this information for providers as well as provider-patient talking points. Some more sophisticated patient engagement tools include predictive modeling and cognitive computing. They are being adopted for intelligent patient engagement, in which programs can help a care manager, for example, prepare for an interview with an individual by providing insights gleaned from a variety of sources, including unstructured documents such as clinician notes and nurse intake questions. This also has a proven benefit for workflow efficiency when care managers typically oversee hundreds of patients. Despite much promising technology, however, the last on the list of technologies, telehealth, is still not as widely adopted as some of the newer forms of technology. for reasons we discussed earlier in terms of licensing, reimbursement, and technology setup. Still, after 25 or 30 years of fits and starts with telehealth, many still believe there is promise in telehealth, and new technological capabilities do continue to be added.